पाठ हो रहा है।
So we'll go ahead. So as I said, at any given in a time of pregnancy, the constipation can affect the life. So up to almost 38% of pregnant women do some amount of experience of some amount of constipation in their throughout 9 months. It is normally it is described as an infrequent bowel movements or a difficulty in evacuation or hard or lumpy stools. In GI studies, there are so many criteria like Rome 4 criteria, Rome 3 criteria, but for a pregnant woman, infrequent bowel movements or difficulty in evacuation or a lumpy hard stools is the criteria considered as a constipation. So extensive evaluation is not necessary for every patient having a pregnancy, but you should have a history of personal history, whether they are having constipation de novo or whether their family history or hereditary constipation is there in the family, or in a background we should ask them about their hypothyroidism status or if they are taking some treatment for hypothyroidism. So in general, everybody knows, you all are learned people, everybody knows that eating too little fiber, not drinking adequate water, lack of exercise is the basic reason of constipation, but this is not the reason, this is an additive factors. So what else is in the pregnancy is important is there are so many hormonal changes. So rising progesterone levels and a decreasing motility hormone will lead to a decreased bowel movements and increased transit time. So increased water absorption are there because of these hormones into the intestine only. So there is the stools becomes hard because of lack of interluminal fluid in the bowel. So there is different reasons also. The another reason is reduced maternal activity. As the pregnancy advances, the maternity activity is also decreasing in nature. So this is an additional symptom. The another cause is lots of iron supplementation and calcium supplementation. They do cause some amount of additive factor as a constipation related one. So later in a pregnancy, the enlarging uterus itself is a space occupying lesion which causes slow onward of. Are you hearing me?
Yes, doctor, we can.
You can hear me, no? There's somebody else told ki
Yes.
listening. I got a message. So sir, there are another reasons. What is the medications ongoing for pregnancy? That is iron supplementation. Sometimes we give in a pre-eclamptic patient or somebody is receiving magnesium sulfate. That is an additional cause. Hypothyroidism can is uncontrolled hypothyroidism is a cause, not a controlled one. So constipation, if at all constipation is what is the disadvantages for that particular female is sometimes it can cause complications like fecal impactions. They do have some amount of disturbances in their routine activities. They do feel low or depression or anxiety is there. There is constipation is the second most common symptoms in a GI tract after nausea and vomiting. But beside discomfort, the constant straining can damage the pudendal nerve and impair the supportive functions of the pelvic floor musculature, which can be in future has got a uterovaginal prolapse additive factor. Sometimes these constipations complaints or depends upon the early phase of pregnancy or late phase of pregnancy. We have to see. You have to treat constipation as a symptom, not as a disease. So two complications are important in a pregnant patient. One is fissure and second is hemorrhoid. There are two more complications. One is fecal impaction, which is little rare but can be there, and other complication is rectal prolapse, which is not seen in pregnant female. That is in a chronic constipations. So what we have to do, avoid constipation, we can avoid complications. So concentrate on the patient's constipation treatment, we can definitely avoid their complications. So everybody knows that we give advice to drink lot of water, lot of liquids. What is mean by plenty of waters, or what is mean by plenty of liquids? You have to assess every patient individually. You have to ask them whether how much water intake or liquid intake they are taking before they are having the constipation symptoms. So we have to add on that amount with an insensible loss up to 500 to 700 ml and 500 plus to avoid constipation. So that 500 to 700 insensible loss is depends upon which type of weather the patient is coming on. Whether it is a winter or rainy season, you have a less insensible loss. But if it is summer season like this, insensible loss is little more. So we have to that consideration. So up to 2.2 to 2.5 liters of liquid is any form, not only water. Too much of overhydration is also bad, but you have to think of any liquid sort of water, coconut water, juices, fruit juices, whatever the these. But that definition of plenty of oral fluid is changed for particular patients. So we again give advice of eating more of fiber diet. What is mean by more of fiber diet? So they have to contain in their diet different types of beans. They have to add on the grains. They have to add on bran, cereals. You have to encourage them to get lots of fresh free fruits and green leafy vegetables in the diet. What is the limitation for them? Limitation from is them. Those are foods which are least in a fiber content like cheese, the foods which are processed. Apart from the food, the time of meal is also a very important thing, because of the hormonal changes, the circadian rhythm of the body changes. The hormonal levels or particular day or particular time is different. So you have to keep, like a diabetic patient, you have to keep a regular meals. So complete diet chart should be there. The timely meal is very important, associated with balance and the nutrition diet. So as most of you are on a good gynecologist or physician, there's no need to explain you all this, but this is important. What is to be avoided? Fried, fatty fluid or fried food or processed food where there's no fiber in the content has to be avoided. I know there is a craving for females in this period, but they have to avoid or restrict this type of foods. All types of junk foods or aerated drinks, too much of chocolates or too much of jellies, which are less in fibers and more of gases, has to be avoided. Oh, there are some unhealthy eating trends. You must have noticed. Even my wife, I have pampered too much. Everybody, pregnancy, the husbands are pampering, the in-laws are pampering, mother and father are pampering. So that pampering gives rise to sometimes irregular meal timings. So skipping meals sometimes happens. So this should not happen. Second thing is craving for sweets, snacks, and drinks. I said it has to be restricted. We have actually nowadays we have got everybody is a working woman, so we have got every pregnancy is a precious pregnancy. Nobody goes beyond 2 children now, normally nowadays. So we have to have a healthy food habits in that incorporated into every patient. So imbalanced meal is also a not good choice. So this is, everybody knows that 40 weeks of pregnancy is a magical time for everybody. So keeping a healthy lifestyle throughout the pregnancy, not only but before and after that, is important. So what is important is balanced diet, gaining of right weight as per your advice of gynecologist or obstetrician. Enjoy the regular light physical activity, which is very important. That is why everybody is coming with, like Vinaya has got so many sessions on training, life activities, and yoga sessions also there. So so many corporate hospitals are putting up some programs for them. So physical activity is important. So whatever the importance is, minerals and vitamins as per your doctor is to be taken. Avoid the drinks like alcohol, tobacco, and any other harmful substances throughout the pregnancy. So when the lifestyle modification or dietary modifications are not enough, then only the role of laxative therapy comes. So every patient we have to treat mostly with a lifestyle modification and the diet and the changes in the meals. And if at all they are still having some symptoms of constipation, then we'll start with the laxative therapy. So we have got lots of laxatives available in the market, but what is important is bulk forming laxatives, osmotic laxatives for pregnancy. Stimulant laxatives we avoid because it causes lots of stimulation, sometimes to the uterine contractions also. Fecal softeners and lubricants we can use. But as I said, there are two types of first line and second line treatment for pregnant female, which is advised by GI surgeons or gastroenterologists. One is bulk forming agents like selenium or methyl cellulose. Second is osmotic laxatives, that is PEG, polyethylene glycol, and sorbitol or lactulose. If at all they don't work, or sometimes you have got a little impaction, we can have a bisacodyl or second line stimulant laxatives. Castor oil and mineral oil of any type is contraindicated in pregnancy. So what is mean by bulk laxatives? So here comes the all types of agar, psyllium, husk, branch, all types of churans, whatever the patients are taking, all types of Ayurvedic preparations. These are bulk laxatives. And we have got a synthetic preparation. I am not a branding anybody, but this is a fake fiber and powders. There are cellulose, methyl cellulose compounds. These are containing. This is considered as the bulk laxatives. So why these are important? These are not absorbed at all in the body. So that is why it is very less risky for a fetal malformations. So these are giving, and the long term use of this doesn't have any side effect. So first line of treatment is the bulk laxatives. So what is bulk laxatives? They absorb the body fluid and makes the stool little soft and a little bulkier. So bulk is also propels the stool material, and the softness caused by the absorption of water gives rise to a get a relief of constipation. But what is the affection or side effect? Some patients do have unpleasant of gas or bloating and cramping pain. So sometimes some patients do not tolerate these bulk laxatives. So what is next? Next is lactulose and a polyethylene glycol, which is also not absorbed systemically. So whatever we are giving to pregnant women, that should not be absorbed systemically, so that it should not cross the placental barrier and cause a fetal malformation or something else. So use of lactulose has not been associated with any adverse effects. So individual problems may be side effects like a flatulence and bloating for all the laxatives is there, but prolonged use can cause a electrolyte imbalance in a theoretical manner, but we have to keep a track on that. So what are the treatment options in spite of these, whether the lactulose is good or PEG is good? So laxatives like PEG has proven safe in mother and fetus. So PEG or lactulose is preferred. Second thing is lactulose should be considered only with the treatment. So these are the two things only, lactulose and a PEG, which are considered safe as osmotic laxatives. So why? There is a basis. American Gastroenterological Association has done a study for GI medicines used in a pregnancy for constipation. So there is a consensus that PEG always better with over the lactulose with a low risk, as it is well tolerated and not absorbed and no side effects for the fetal. So there is another Cochrane study which has got a meta-analysis of drugs used in pregnancy for constipation. So they also have proved in 2011 itself that PEG is better than lactulose, which is regularly we use. So what are the stimulant laxatives? So bisacodyl or jabisa, or you have some Dulcolax tablets, or these are Dulcoflex tablets. These are the bisacodyl suppositories. They are more for acute impactions, but they do cause, because they have got a strong action, that is why they do cause some amount of crampy pain in the patients. So we have got good osmotic laxatives like PEG and lactulose. So bisacodyl is only for bowel preparation or before starting for any surgery in pregnant patients. So what is the take-home message for constipation? So constipation is the most common complaint. Main treatment involves the intake of good water intake, fiber intake, dietary plans, regular meals. Use of laxatives is only restricted to those who are not responding to any type of conservative treatment. Enemas generally is not given except for the preparation of surgery, and definitely PEG scores over the lactulose or other drugs in any form. So what are the complications? The complications are two, mainly in females is pregnant females is fissure, and second is a hemorrhoid. So what is mean by fissure? We'll just have a small video of that. So fissure is a linear crack or cut or any injury to the anal mucosa because of the hard stools or because of the straining. So it may be a acute, it may be a chronic, or it may be a acute on chronic presentation. So history always matters whether these patients are having constipation or related complications prior to pregnancy only. So that is very important. So most common site is 12 o'clock or 6 o'clock position, but the symptom is the pain. Bleeding is not the main symptom for fissure, pain is a symptom. Sometimes it is so excruciating that females do have got fear to pass the motion, and then it becomes a vicious cycle. There is a constipation, there is a hard stool, they strain, they get a fissure, then they get an anal spasm, and the reverse, that once the anal spasm is there, then again a constipation, again a straining, and the fissure goes, the cycle goes on. It is a vicious cycle. We have to stop somewhere it, else then only the patient will be getting benefited. So the bleeding is very rare. It is associated with stools or after defecation only. It may be only a spotting. Rarely it is a large amount of bleeding, but this pain is definitely persistent even in spite of few hours after defecation. But the chronic and acute, the differentiating thing is a sentinel tag or stretched skin. If there is a associated stretched skin, it is a sign of a chronic fissure. Maybe this patient may be presented with acute or chronic symptom. So once the fissure is there, how to treat this fissure? The first line is only mainly treating the constipation. As we have seen, the constipation treatment, fluid, fiber, avoid drugs, regular meals, balanced nutrition, treatment of if hypothyroidism is there or not. So apart from that, what is the local treatment is warm seeds bath. I prefer personally a potassium permanate because we can quantify potassium permanate. Dilute betadine is comes in, nobody knows how much is the dilution for that particular patient to have a skin reactions. So betadine is comes in 5% or 10%, but potassium permanate we have got a powder, so we can have explain the patient is pinch of powder is more than sufficient. The color of the water should be purple, so they should not have a excess quantity, because whatever we do, either betadine or a large amount of potassium, they do have a perineal excoriation or something. So we have to limit that powder intake in a water. So simple thing is xylocaine jelly. Digital application is more important. Whatever the jellies or ointments we have got, they have got a small stilette like opening, and that is not the size of the stool we have. So what we have to tell them is proper application. You have to use a glove finger and use this finger to put inside your anus and then come out. So till the spasm goes, you have to put the finger with the ointment finger 3 times a day, in the morning, 3 times in the afternoon, 3 times. So this is called a digital dilatation of the anus. If at all we use that applicator is too small. It is easy to apply, but it doesn't dilate. So what we have to tell the patient is manual dilatation, that is digital dilatation, because the stool size never comes to what the applicator size comes. So only application is not important, how to apply is more important. Sometimes these two patients do require a suppository, which can be in a paracetamol suppository. Sometimes we have to give an oral paracetamol. Diclofenac suppository are good enough, but last trimester of pregnancy we have to just be cautious, because on theoretical grounds they do cause a premature closure of patent ductus arteriosus. Oral NSAIDs, as per the obstetrician gynecologist, patient can have. Two types of ointments are there, very good ointments, diltiazem and nificaine. These as very good ointments, they are very less systemic absorption, but still the safety in pregnancy is not documented. But application, if at all in a rare condition, we can use. Surgery is a last resort, but still, if the patient has got acute fissure, they cannot tolerate, they are afraid of pain, we can do it's in a under pudendal block. We can do a closed internal sphincterotomy or open internal sphincterotomy. It's matter of only 15 minutes, and we can do under pudendal block. In Western countries, they do give a Botox injection, but there is no trial for the safety of pregnancy in a Botox. Botox is a neurotransmitter which causes a smooth muscle relaxation. In a local injection, we can give, but safety of trial in pregnancy is not yet proven. Second most common is a hemorrhoid. So what is hemorrhoid? Is dilated venous plexus. Chronic constipation and a straining is the main cause. But increased blood flow in a pregnancy, changing hormonal levels, and a pressure of the gravid uterus is the additional causes for females. Internal and external, both are hemorrhoids are there. We have got a, as a surgeons, we know that there are grade 1, grade 2, grade 3 hemorrhoids. There are internal hemorrhoids, there are external hemorrhoids. What is mean by grade 1 is less than 25% circumference is occupies the anal mucosa. Grade 2 is 50%, grade 3 is 75%, grade 4 are prolapse hemorrhoids which can be seen on a naked eye and outside. There is a component that external hemorrhoids which can be easily seen on naked eye as it is prolapsing out of the anal canal. So most common site is 11-3 or 7 o'clock position. Why? Because there are more of renal anorectal veins are prominent on this area. But it is not a mandatory. It can be a diffuse or circumferential presentation. Those hemorrhoids or those patients, when the patients start these hemorrhoids during the pregnancy, it increases throughout the pregnancy as the pregnancy goes on. But if at all patient has got already existing hemorrhoids, they do worsen during the pregnancy progresses. So what is the symptom? Is the painless bleeding is the symptom for hemorrhoid. Fissure always will have pain. Hemorrhoids will rarely have pain. That is the two differentiated symptoms. So what is sometimes patient feel? External hemorrhoids, they do cause small swelling. What as patient complaints are, sometimes they have got burning sensation, sometimes they got tenesmus, or sometimes they have got just a discomfort in anal region. So that may be a presenting symptom. Sometimes these patients will present with a prolapse or thrombus hemorrhoids. What is meant by prolapse and thrombus hemorrhoids is the hemorrhoid which is have got a thick blood clot and which comes out of the anus and causes a mass like appearance. So this time only when there are thrombus hemorrhoids, then only the patient will have pain. Otherwise, hemorrhoids are always painless. So bleeding is the main site. Sometimes it comes with the stool, or sometimes it may come after the stools, and sometimes it is very much high in a pressure, or it comes like a spurt because it's a venous blood. So streak of flow is very rare, but most of the times it is a spurt. So once we know that hemorrhoids, what is the treatment, which is the important thing. Uh, always says that hemorrhoids is secondary to constipation. The first line of treatment is the constipation treatment. As I know, I will not repeat again the constipation. What you know that everybody has discussed this. So what is the aim? Aim is that to stop the bleeding and control the symptoms. Do not worry about the curative treatment of hemorrhoids in pregnancy. The reassurance of the patient is very important that those hemorrhoids which are started or de novo with pregnancy, they will definitely resolve after the pregnancy once the uterine pressure is there less gone in the after delivery, and the congestion of the pelvic floor is reduced. Most important is seeds bath with fissure is very much definitely helpful, but extra in hemorrhoids it is only for external hemorrhoids. Seeds bath doesn't have any role in a hemorrhoids per se in internal conditions. But sleeping on one side or lateral side do causes decongestion, as also we know that left lateral position gives rise to little decongestion of or pressure alignment from the IVC. So less of venous engorgement is there. So position of sleeping is also pattern is also to be explained to the patient. Grade 1 definitely doesn't require any treatment if the patient has got very minor bleeding or just a discomfort or rarely do have painless bleeding. Just give them a constipation treatment. Sometimes just for the burning or anal discomfort, you can use a xylocaine jelly. And if at all they are still having some amount of discomfort, you can just give a paracetamol. But grade 2 and grade 3 definitely bleeding is more, so we have to just tackle these problems in pregnancy. Most importantly is calcium dobucillate ointments which are there in the market. We have got, everybody knows, we have got a Ocil cream, we have got a smooth creams. There are lots of creams. Calcium dobucillate is there. It is not absorbed when applied locally, but calcium dobucillate tablets is to be avoided because it can cross the placental barrier, and even it is in a avoided, it should be avoided in a lactating females. So what else we have got for the bleeding? So we have got a tranexamic acid which is considered as a safe drug. You can give 500 milligrams twice or thrice in a day for 5 to 7 days and just treat the constipation. Once the bleeding is stopped, you can just treat the constipation and stop the medicines. What is if at all still patient has got symptoms or bleeding? So what we have got a micronide flavonoids which has been time tested for pregnancy. It is called as, it comes in a brand name as Daflon. Nowadays we have got a Daflon 1000 milligram also. It is first 3 days is 3 tablets for first 4 days, then 1 tablet BD for 3 days, and then 1 tablet OD for next 7 to 15 days till the bleeding stops. So what is important is glycemic dressing is only for that thrombose and external hemorrhoids. If it is too problematic, we can do a surgery under local anesthesia for that thrombose hemorrhoids. But surgery, as I said here also, it is a last resort. Whatever we do is office procedure for active bleeding, like a band ligation can be done on OPD procedure. Sometimes we give sclerotherapy or laser treatment that can be under regional anesthesia or a pudendal block. So that is very important that surgery, if at all we want to do it, is to be done in a second trimester only, which is that is a safe period. So here at all we have finished everything. Just if at all any questions are there, I'd like to answer.